Good evening, everyone. Myself, Dr. Pandu, Consultant Pediatric Gastroenterology at KIMS Cuddles, Hyderabad. Today, we are going to discuss regarding acute abdomen in children. So, today's outline of today's discussion is like what is acute abdomen and what is the epidemiology, what is the pathophysiology of acute abdomen, what is the etiological profile, and how to diagnose and evaluate further, and algorithmic approach involving all physical examination, investigation, and history. Then let us look at few case studies. So, what is acute abdomen? It is a clinical syndrome characterized by the sudden onset of severe abdominal pain, requiring urgent evaluation to identify potentially life-threatening conditions that may necessitate immediate surgical or medical intervention. This is a definition adopted by the Special Interest Group and Acute Diarrhea from European Society of Pediatric Gastroenterology. One more similar definition by the surgical textbook from Das surgical textbook. Similarly, it's a clinical syndrome characterized by the sudden onset of severe abdominal pain. Here, they stress on the intra-abdominal condition and possible surgical intervention. Overall, it is the same. So, acute abdomen itself is a syndrome. It's not a single diagnosis. It contains multiple diagnoses and different etiological profile. So it is a clinical syndrome. It needs to be evaluated step by step according to the history, examination, and other presentations. What is acute abdomen? So pain abdomen, it persists less than 5 days. It may be intra-abdominal cause, thoracic, systemic, and may require urgent intervention. So acute means it should be less than 5 days. Okay, it and can be extra-abdominal cause as well, like in myocarditis and congestive cardiac failure. That the cause is the thoracic, but the pain abdomen can present with because of the CHS hepatomegaly. And pneumonia can cause severe abdominal pain in case of lower lobe pneumonia. Okay, so that underlying cause can be either thoracic or it can be the other systemic cause as well. Let us look at the epidemiology. So acute abdomen contributes 5 to 10% of the pediatric emergency visits. It is all over the world. It may be in some part of the regions, it may be more, and in some specific regions, it can be more as well. So majority of the pediatric abdominal complaints are relatively benign. So like constipation, functional pain, irritable bowel syndrome. But it is very important for us to pick up some cardinal signs that may suggest a more severe underlying cause. That's why we need an algorithmic approach as well as the systemic examination of the child. When it's come to so it contains both surgical and medical conditions. Most of them are medical conditions and benign. They resolve with the intervention, mild interventions. And when it's come to the surgical conditions, prevalence is 1 to 5% of the all acute abdomen. Most common surgical cause is appendicitis followed by intussusception. So what is the neurologic basis of the abdominal pain? The abdominal pain can be visceral pain, parietal pain, and referred pain. Okay. So depending on this explanation, like parietal pain, we can explain the even extra abdominal causes of the pain abdomen. Visceral pain will definitely know these intra-abdominal causes, and parietal and referral pain can explain the extra abdominal causes of the abdominal pain. At the same time, abdominal pain presenting as the extra abdominal features. So visceral pain is due to a direct involvement of the nerves innervated by the visceral organ. Okay, the visceral pain fibers are bilateral and unmyelinated and enter the spinal cord at multiple levels. Visceral pain is generally dull, poorly localized, and felt in the midline. So more the pain in the midline, more likely it is like dull pain, and it is more likely visceral pain, which is most of the time it is functional pain, or later it can get localized to the other areas of the pain as well. So we need to closely watch as well in sick children. When it's come to the parietal pain, it is due to the involvement of the parietal pleura or abdominal wall. Okay. Here the pain results from the ischemia, inflammation, stretching of the parietal peritoneum, is transmitted through the myelinated afferent fibers to the same site at the same dermatobal levels as the origin of the pain. It is always, most of the time, it is localized pain, sharp, intense, and discrete, and localized. Okay, and coughing and movement can aggravate this pain. So parietal pain is always far away from the midline, and it is localized at a place, and it is sharp, intense, and it triggered by the movement and examination, deep palpation, and coughing as well. When it comes to the referred pain, it is due to the shared central pathways from for the afferent neurons from the different organs. For example, so let us look at the results from the shared central pathways for afferent neurons from different sites or different organs. Okay. The classical example is patient with pneumonia who present with abdominal pain because the T9 dermatome distribution is shared by the lung and abdomen. Similarly, pancreatic pain can be referred to the back. Here, the T1 to T5 dermatomes, which innervates the pancreas, share that enters the T1, T5. At the same time, the innervation of the back, somatic innervation of the back, also enters to the T1 to T5 dermatome. How that pancreatic pain is referred to the back. So referral pain is due to the shared central pathways for the afferent neurons from different sites or organs. Sometimes, so we have seen that three major mechanisms of pain, like visceral, parietal, and referred pain. Some pain, sometimes the pain abdomen is not readily explained, like in tonsillitis with high fever, pharyngitis, viral syndromes, streptococcal pharyngitis. These children can also have pain abdomen, but there is no readily available triggers like neurophysiological explanation for this. It may be due to the central hypersensitivity or involvement of other factors like fear, anxiety, all those things can present as abdominal pain, which is mostly like centrally located and self-resolving. So acute abdominal pain, it can be either dangerous intra-abdominal cause such as appendicitis or may originate from the extra-internal sources. This is a summary from the neurological basis of the pain abdomen. Okay, let us look at the etiological profile of the pain abdomen. So majority of the causes are intra-abdominal. When you look at the intra-abdominal causes, gastrointestinal causes like hepatobiliary causes, genitourinary causes, and some gynecological causes. These are the predominant intra-abdominal causes. When it's come to the extra-abdomen, like cardiac, pulmonary, hematologic, and few metabolic like diabetic ketoacidosis, neurological causes, toxins and drugs, and few miscellaneous. Okay. When it's like, so these are the intra-abdominal, intra and extra-abdominal causes of the pain abdomen listed. Let us look at the age-wise differentials. When it's come to the neonates and infants, infantile colic followed by gastroenteritis, constipation, Hirschsprung disease, incarcerated hernia, intussusception, volvulus, and urinary tract infections are common in neonates and infants. When it's come to children, gastroenteritis is most common, followed by appendicitis, constipation, functional pain, diabetic ketoacidosis, urinary tract infection, trauma, pharyngitis, pneumonia, HSP, and mesenteric lymphadenitis. When it's come to adolescents, appendicitis, gastroenteritis, constipation, dysmenorrhea, pelvic inflammatory disease, ectopic pregnancy, and few gynecologic causes as we have described, and it can be the IBD, inflammatory bowel disease, and pancreatitis. When you look at this etiological profile, look at the constipation. So it is seen in all age groups as the third most common. So overall, it is the most common cause and benign cause of the intra-abdominal pain abdomen. Okay, others can be like functional pain abdomen. Okay, followed by the surgical causes, like most common is appendicitis, and others are intussusception, especially in the infants and toddlers. Okay, so this age appropriate differential need to be aware of every pediatrician to early identification of the diagnosis for the which guides the further management and appropriate management of the child. So this we have seen the epidemiology etiological profile. Then let us how to approach a case when it's present to the like emergency room. So initially, when a child present to emergency room with pain abdomen or acute abdomen, we need to first initially assess the ABCD survey, primary survey, secondary survey, and stabilize the child initially. Followed by he need to be taken like secondary and tertiary evaluation like focus history examination and targeted diagnostics and early involvement of the surgical consultation as well as a supportive care need to be started up. So in the primary survey, look at the airway assessment. As we discussed, that pneumonia can also present with severe abdomen. Subtle pneumonias can be there, but otherwise systemic involvement can have pain abdomen initially. So breathing, circulation, disability, and exposure. Any trauma child can present with disabilities. And also look at this like diabetic ketoacidosis can have like pale or shock. So we need to look at this survey and initial resuscitation after the primary assessment, and then if history of hemodynamic instability with trauma, we need to perform this focused abdominal sonography in trauma. Okay. Place to large bore intravenous lines. If patient is hypotensive, administer a bolus of intravenous saline. And if patient there is intestinal obstruction with intestinal distension and persistent vomiting, insert a NG tube as well. Then let's move to the like diagnostic evaluation with focus history examination and initial investigation. So important clues to the diagnosis can be determined by history and examination. Okay, in history, like onset of pain can provide us some clues, like events that occur discrete, abrupt onset, such as passage of a stone, perforation of viscous, infarction, result in sudden onset pain. Whereas gradual onset pain is common with infectious or inflammatory causes such as appendicitis or IBD. In appendicitis, initially pain will be in the periumbilical, which is the referred pain. Later, it can localize to the right-sided right iliac fossa. So here the pain is gradually progressive and may have systemic features like fever and anorexia, nausea, vomiting. So here the onset of the pain gives us a clue to the underlying diagnosis. And at the same time, along with onset, we have to consider other features of the pain as well, like nature, location of the pain, very important again, and fever, like and extraintestinal symptoms and course of symptoms. So onset we have already seen whether it is sudden, gradual, prior episodes are associated with means or history of injury. Nature, it can be sharp versus dull pain, colicky or constant, and burning pain. Burning pain can mean the like epigastric with chronic gastritis. Okay, sharp pain can see in the colicky pain and pancreatitis, and constant pain you can see in the pancreatitis as well. When it's come to the location, this is very important. Epigastric pain can be due to the hepatitis and majorly the gastritis and peptic ulcer disease syndrome. Followed by it can be the like hepatitis and as well as cholecystitis. Periumbilical pain is mostly functional or secondary to the constipation, or sometimes can be the referred pain of initial phases of the appendicitis. Generalized pain mostly functional, or it can be the peritonitis along with guarding and rigidity. Right or left lower quadrant pain can be seen due to the right lower quadrant pain can be seen in the appendicitis, left lower quadrant can be seen in the like renal or constipation. Change in location over time is seen in like appendicitis, initially periumbilical, then relocalized to the right iliac fossa. Presence of fever suggests some appendicitis or other infection source. Extra-intestinal source symptoms can help in the look at the systemic evaluation, systemic involvement, or the complication of the intra-abdominal causes. Worsening or improving. If improving or if worsening symptoms, it involves the further worsening of the underlying cause. Apart from the pain characteristic features, we should ask about the triggers of the pain, whether pain worsens or and the movement, or what are the bowel movements like the size of the stool, hard or soft, or odor of the stool. Constipation can have large volume stools, hard stools, and foul smelling stools. Okay. And also ask regarding the foreign body object and dietary history. Look for the in young children, too much milk can lead to constipation with the different mechanisms. And also ask about the medical history and medical comorbidities like cystic fibrosis, pediatric gallstone, and biliary pancreatitis as well, cholangitis, cholecystitis, spina bifida, cerebral palsy, developmental delay predisposed to the constipation, sickle cell disease predisposed to the splenic autoinfarction, as well as vaso-occlusive splenic infarcts in the liver as well as spleen, and child can present with even crisis as well. Vaso-occlusive crisis. Recurrent respiratory infection can suggest mesenteric adenitis as well. This is the history very important. So here, as we have seen earlier, that how onset can give you the clue. Similarly, the location also gives you the clue. Like right hypochondrium, like gallstone, cholangitis, hepatitis, liver abscess, and cardiac and lung. And right lumbar can be ureteric colic, pyelonephritis. Iliac can be appendicitis, Crohn's disease, cecum obstruction, ovarian cyst, ectopic pregnancy, hernias. Hypergastric can be testicular torsion, urinary retention, cystitis, and placental abruption in adolescents and little older. Left iliac can be predominantly colitis, constipation, ovarian cyst, and hernias. Left lumbar predominantly ureteric colon. Left and right lumbar you have ureteric involvement, urological involvement. Okay. When it's come to the left hypochondrium, the underlying organs like splenic abscess, acute splenomegaly, and spleen rupture due to the secondary to trauma. Epigastric, it can be esophagitis, peptic ulcer, perforator ulcer, or pancreatitis. Umbilical pain is majorly early appendicitis. It can be others are mesenteric lymphadenitis, diverticulitis, and lymphomas. So is it depending on the pain casting features like onset, location, referral, quality of the pain. So this can be the different functional syndromes or from different clinical syndromes. Functional pain can be the recurrent onset, location periumbilical, no referral with dull, crampy, intermittent pain. So it can be due to the secondary to the stool, like family stress, school phobia, diarrhea, constipation, hypersensitive pain from distension as well. Reflux can be predominantly substernal pain, referral to the chest. Most of the adolescent children present with like chest pain as well as substernal pain. It is burning in sensation, aggravates on meal. Okay, so sore taste in mouth and Sandifer syndrome can be seen in infants and toddlers. Duodenal ulcer again can be epigastric pain radiating to back, severe burning. It typically it relieves by the food. When it's come to the reflux and gastritis, they are aggravated by the food, whereas duodenal ulcers is relieved by the food. Pancreatitis pain is again acute onset, epigastric, radiating to back, constant sharp pain. So it aggravated by the food intake again, and it can be associated with nausea, emesis, and marked tenderness on the examination. Intestinal obstruction can be acute or gradual, periumbilical or lower abdomen, referred to back, alternating cramping, colic pain, and interval painless periods. Abdominal distension can be seen along with obstipation, bilious emesis, increased bowel sounds as well. Appendicitis, acute onset, initially periumbilical, followed by right iliac fossa, back or pelvis if retrocecal appendix is there, sharp steady pain. Meckel's radiculum, recurrent pain, periumbilical, so it associated with hematochezia, painless intussusception, diverticulitis or perforation. IBD, it is recurrent pain, depends on the site of the involved. If only ileocecal involvement is there, can be right quadrant pain. Left-sided colitis can be the left-sided pain involvement. The small bowel involvement is that can be cause generalized pain in abdomen as well. Intussusception, again periumbilical cramping pain, and there can be the position is important. The guarded position with knees pulled up, red currant jelly stools, and lethargy. Should have a highly suspicious infants with dysentery as well, and in this kind of crampy pain with positioning. Other symptoms can present with lactose intolerance, recurrent diarrhea, with lower abdominal pain, with distension, gases, with perianal rash. Urolithiasis can be the sharp, sudden pain, the lower back pain with referral to the groin region. Colic pain may associate with hematuria. Pyelonephritis, acute onset, referral to the like, acute onset sudden back pain, dull to sharp, so may have fever, costochondral tenderness, dysuria, urinary frequency analysis. Cholecystitis and cholelithiasis. Right upper quadrant pain radiating to the right shoulder due to the involvement of the phrenic nerve and have right shoulder innervation C3 to C5 can leads to the right shoulder referral pain. So may have hemolysis, jaundice, nausea, and emesis. So depending on the location, the pain characteristics, we can come to the differential of the intra-abdominal and extra-abdominal causes of the pain. Let us go to the abdominal examination on the overall examination. So general, there should be growth and nutrition should be uh, taken care. Like in Hirschsprung disease, there can be involvement of the poor growth, anemia, and in case of intussusception, appendicitis, there can be poor oral hydration, which lead to the dehydration, shock as well. And intraabdominal bleeding can lead to the shock. So overall, general examination need is very important and part of the physical survey. And when it's come to the abdominal, like look at the tenderness, distension, bowel sounds, rigidity, guarding, and mass per abdomen. Also look at the genitalia. So testicular torsion, hernia, pelvic inflammatory disease, ectopic pelvic, you can see the discharge as well as some swelling in the inguinal region and swelling of the even testicular or region. We'll also look at the other system examination like breath sounds and respiratory rate, the work of breathing, and abdominal wall structure like trauma to the abdominal wall, ribs, and costochondral joints. Rectal examination is important initially in the whether it is exerted bowel sound or upside bowel sounds to look at the fecal masses or to look at the fecal impaction or blood stained cases in case of hematochezia to look for any palpable polyp and any other causes. So after this, yeah, it is a physical examination and the history. We need to look for the red flag signs in every case. So these are the red flag signs. So like sudden onset of severe pain, pain that interrupts sleep, bilious vomiting, hematemesis and hematochezia, patients lying very still, jaundice, and other high risk patients like previous abdominal surgery, history of cardiac disease or atrial fibrillation. These are uh, red flag symptoms as well as red flag signs like guarding or rigidity, rebound tenderness, hypotension, tachycardia, absent or tinkling bowel sounds, and gross abdominal distension. So we need to look at this red flags in every child with acute abdomen present to the emergency room. Presence of any red flags warrants a urgent evaluation and involvement of the multi-specialty team according to the etiology. Let us look at the investigations. So these children needs focus investigation and target investigation. Like in trauma, we need to look at the initially fast followed by the other investigation. Abdominal X-ray is also usually obtained in cases of like periumbilical pain and fecal staining and distal examination when you are suspecting with no red flag signs. Even whenever there is red flag signs with intestinal obstruction, the X-ray series also obtained. Further imaging studies may be warranted to identify the specific cause according to the history and examination. When there is high suspicion of appendix, but the ultrasound and examination doesn't give the clue, you can go for CT scan as well. If there is history and other features interception, USG is the first child to diagnose and treat this condition with hydrostatic or pneumatic prediction. So after initial examination and history, we need to perform the targeted investigation. So always in every child with fever and other um, red flags signs, always involve with laboratory like CBC, CRT, ESR. And whenever there is jaundice, look for the biliary or liver disease. Amylase lipase for the pancreatitis, urinalysis for the urinary tract infection or cystitis or other uh, like lower back pain with the hematuria. So pregnancy test for the adolescent and older women with history of acute pain abdomen secondary to the torsion or involvement of the hemorrhagic cyst. Radiologically, so upright abdominal films and plain flat films are important to look at the bowel obstruction, appendical leak, free intra-abdominal repair and kidney stones. CT scan to rule out and to establish the diagnosis of like appendicitis in some cases and Crohn's disease, pancreatitis, gallstones. Whenever there is a doubtful pancreatitis, you need to do CT scan. and other cases when you are suspecting the complications as well. Ultrasound is helpful in the gold standard like in gallstone, intussusception, and also helps in most of the cases diagnosed on ultrasound itself, appendicitis, pancreatitis, kidney stones. Upper GI endoscopy is needed in the peptic ulcer disease or esophagitis. So these are the examination, investigation, radiological and laboratory investigation. Now after this evaluation, we need to find out the differential diagnosis. Okay. So in young children, it can be acute onset pain. The emergencies, surgical emergencies are like malrotation, incarcerated hernia, congenital anomalies, and interstitial are more common concerns. Older children and teenagers, appendicitis is more common. Acute surgical abdomen is characterized by signs of peritonitis, including tenderness, abdominal rigidity, guarding absent or diminished bowel sounds. So these you can differentiate according to the age of the child, which warrant the surgical emergencies and involvement of the surgical consultation early in the course of the evaluation. So we can see the same thing in a algorithmic level. So this simple algorithm to summarize everything. Okay, pain in abdomen less than 24 hours along with abdominal distension, focal tenderness, involvement of peritonitis. If child is sick, associated with severe pain as well as involvement of the vital signs like tachycardia, hypotension, urgent evaluation with plain abdominal filling, urgent surgery consultation need to be taken, and appropriately ultrasound if required, CT as well. Okay. It can be the most of the time perforated viscous or bowel perforation, intra-abdominal hemorrhage, necrotizing enterocolitis in the preterm infants, valvulus in the infants, and mesenteric infarction. When it's come, we are suspecting only intestinal obstruction. Okay, like bilious or feculent emesis. Plain abdominal film along with the surgical consultation, ultrasound abdomen. So here, when you are involving the intestinal obstruction with severe shock, involve surgical consultation consider early in the course of this. If it is a neonate, it can be valvulus. 2 months to 2 years in toddlers, it can be intussusception, Hirschsprung disease, incarcerated hernia. In older children, it can be adhesions with history of previous surgeries. When you are suspecting appendicitis alone, look for the complete blood count, urine analysis, surgical consultation, ultrasound abdomen, if required, CT, and further proceed for the laparotomy. Suspicion of hepatobiliary disorder, go for the and like malaise lipid liver function test, abdominal ultrasonography, if required, other investigation according to according to the diagnosis. Acute pancreatitis, acute cholecystitis, cholangitis, and cholelithiasis can be seen in the hepatobiliary disorder. This is one more algorithm. So one by one. So here, look at for any trauma. If any no trauma and presence of fever is there, then look for the UTIs, gastroenteritis, mesenteric lymphanitis, pneumonia, appendicitis, and PID, pelvic inflammatory disease. Any evidence of sickle cell anemia in the past or known case of sickle cell anemia, look for the sickle cell crisis or vaso-occlusive crisis, which can involve hepatobiliary as well. Only left-sided pain, look for the constipation, ovarian testicular torsion, or Mittel-Merz syndrome can be seen in adolescents in the beginning of the menarche. So middle to right-sided pain, then look for the appendicitis, ovarian testicular torsion, mesenteric lymphanitis, and mitral. This can be seen in both sides of the flank. Pain in other household contacts, present in other household contacts as well. Then similar symptoms in other household contacts like vomiting, pain abdomen, it indicates either food poisoning or food associated infection like gastroenteritis. Any sexual activity, it can be pelvic inflammatory disease, ectopic infection, especially in older female or adolescents. Painless purpura, then you need to look at the hemolytic uremic syndrome, hemochromosome purpura. Blood in stool, yes, it can be the inflammatory bowel disease, dysentery, or it can be the HSP as well. Any hematuria, look for the renal calculi, renal trauma, urinary tract infection, evidence of an obstruction, so malrotation, interception, valvulus, and look for, if nothing is found, and then look for the other causes like functional pain causes. Okay, this is one by one, you can see here. it involves other like other than intra-abdominal, we need other systemic involvement also. So key points is the determine if abdominal pain is acute or chronic. Is it acute abdomen or surgical or medical or benign condition? Are there any red flag signs, symptoms are present? So this is the overall approach to the acute abdomen. Now let us look at the case studies one by one. We'll have the three case studies. With a 6-month infant presented with vomiting and severe crying since early morning associated with poor food intake and abdominal distension. Otherwise healthy infant, no previous feeding intolerance, looks well, chubby, and the mother says intermittent severe abdominal pain. Mother says patient pass reddish thick mucus stool. Physical examination show normal febrile irritability and excessive sweating. Abdomen, there is a palpable sachet-shaped mass in the right upper quadrant. Other systems are remarkable. So anybody in the room want to tell their differentials? So 6-month infant with acute abdomen with other symptoms like reddish thick mucus stools and irritability, and there is mass palpable, sachet-shaped mass palpable in the right upper quadrant. So anyone, what is the next step in this child? Okay, so we have already given adequate history and examination finding. Then we have to proceed for the investigations. So this is supine abdominal X-ray. Here, depending on this pain, we can depending on the symptoms, it is acute abdomen with probably suggestion of intestinal obstruction. It is different. It may be the intussusception or intussusception or other causes. So here we need to look at the X-ray abdomen to look at the air fluid levels as well as the air under diaphragm as well. Here you can see there are no like fecal impaction or air under diaphragm. There is a distended large bowel loop here. Otherwise, no other symptoms. So there are then we'll further look further with ultrasound abdomen as well. So in the ultrasound abdomen, you can see these two concentric alternating rings with hyperechoic and hypoechoic. So this is hyperechoic and this hypoechoic concentrating rings. Okay. So this is target sign seen in intussusception. So here that longitudinal views explains you the bowel within bowel pattern. So or pseudo kidney sign here. So next treatment is involvement of the surgical department and urgent pneumatic or hydrostatic reduction. Most of the time we will be performing hydrostatic reduction in our unit. If child present early, and here but the you can see most of the time when our child already having red currant jelly, preferably is the surgical involvement because disease is advanced that may not improve with hydrostatic reduction. So child present early after the onset of the within 24 hours of the pain onset and with no much hematochezia, then we can look for the hydrostatic reduction. If late in the course, then go with surgery. So after the pneumatic reduction, you can see here that the large bowel distension is disappeared and overall normal bowel gas pattern is obtained here from the ascending transverse and left side colon and sigmoid bowel pattern is normal here, which in the earlier X-ray we could not see the exact bowel gas pattern. So there is opaque radio abdomen here with only few bowel gas pattern here. There is positive bowel gas here in the case. So case 2, a 3-day-old firstborn term male infant, uneventful perinatal course, discharged at 12 hours of age. His mother complained of continuous crying and notes that he initially fed well but has been vomiting for last 24 hours. The vomiting initially considered of milk but Now slightly green tinge. His mother feels his abdomen is firm. He passed a small amount of meconium for the first time today. He had no fever and has been alert and active. So here, an examination, you can see vital signs are normal. Abdomen is markedly distended without mass, non-tender to deep palpation. Distal rectal examination show passage of the large amount of meconium. Lab studies and electrolytes are normal. So here, day 3 of infant, okay, with first time meconium passage and day 3 of life. Delayed passage of meconium along with grossly distended, markedly distended abdomen, okay, with no localization. And distal rectal examination, registry of fecal staining, like large amount, passage of large amount of meconium, okay. So what could be the differentials? Delayed meconium passage, gross or markedly distended abdomen with meconium stain, distal rectal examination with involvement of other lab parameters are normal. What are the differential at this point of time? So delayed passage of meconium can be seen in Hirschsprung disease, can be seen in cystic fibrosis. So differentially it can be like Hirschsprung or meconium ileus. Okay, this can be the initial differentials. So it is the X-ray abdomen. Here you can see a large bowel gas pattern. This is case of dilatation of the large bowel, especially left-sided colon. Okay, and this gas pattern, when it traces to the rectum, you can see there is sudden narrowing of the gas pattern followed by narrow pattern of the gas pattern. Here it is some transition zone. So large bowel gas pattern followed by the narrow stream of the bowel gas pattern. So the proximal bowel is distended and distal bowel is narrow, which is reversed compared to. So generally, there is 369 rule. Small intestine is 3 centimeter size, large intestine is 6 centimeter, and rectum is 9 centimeters. Okay, this is the general for adults. However, you can extrapolate into the children's as well. So, according to the 369 rule, that rectum should be mostly distended. However, here you can see from this transition point, there will be narrow bowel involvement and narrow rectum. So there is a reversal of the rectosigmoid junction here. Okay. So that means the distal part is further narrowed and proximal part is highly distended. So this is seen in Hirschsprung disease. Down. Okay. So what is the next step? So we have to stabilize the child, and then we have to definite further definite investigation by the full thickness rectal biopsy and surgery. So surgery can be done in the for one step or two step surgery. So these are the different surgical methods for the management as well. So totally transanal endorectal pull through preferred method then can be done in one stage. Abdominoperineal pull through, so can be done two-stage procedure as well. So this is the one more case. A 14-year boy brought to the emergency department with diffuse abdominal pain, vomiting, and altered level of consciousness. The patient's symptom began several days ago when he complained of the flu. His symptoms at that time included profound fatigue, nausea, mild abdominal discomfort, and some urinary frequency. Today, he was found in bed, moaning but otherwise unresponsive. His past medical history is unremarkable and he is currently taking no medications. So, history-wise, what are the important clues here? Acute abdominal pain, okay, with vomiting and altered level of consciousness with history of urinary frequency, okay, polyuria you can say. It started with a few upper respiratory tract infection. So these are the clue from the history and examination. You can see there is a hypothermia, tachycardia, hypotension. So head and neck examination showed dry mucous membranes and sunken eyes, and there is unusual odor to his breath. Important clue again. Lungs are clearly bilateral and increase rate and depth of respiration. Cardiac examination reveals tachycardia, no murmurs, rubs or gallops. The abdomen is diffusely tender to palpation with hypoactive bowel sounds and involvement of Gordon. The rectal examination is normal. Skin is cool and dry with decreased torture. In neurological examination, patient moans and localized pain but does not speak coherently. Okay. So here we have many clues. Now let us see the laboratory investigation. Hemoglobin hematocrit levels are normal. Leukocyte count is elevated like 16,000 cells per microliter. Electrolytes means sodium of hyponatremia and hypokalemia. Chloride is 98 millicoulombs, bicarbonates 5 millicoulombs. So bicarbonates 5 here may suggest some acidosis. So we need to evaluate blood gas analysis as well. Blood urea and creatinine are mildly elevated. The serum glucose is 740 milligram per deciliter. Other investigation are normal. The 12-lead ECG is sinus tachycardia, his chest X-ray is normal. Okay. So hyperglycemia with hypoelectrolytemia with shock and as well as polyuria in the history as well as acute abdomen with dehydration as well as an examination. So what are the diagnoses here? Straight away, this is diabetic ketoacidosis. Okay, with no issue. So first time diabetes with diabetic ketoacidosis. Okay. So next step in the management the fluid resuscitation is very important. Okay, followed by 1 hour after the fluid resuscitation, you can start acting insulin, and also we give additional electrolytes in the the fluid resuscitation. If required, to admit in the ICU and involve the pediatric endocrinologist if available in the near. So these are the 3 cases. Take home message is like early resuscitation and stabilization in sick cases is important. Early identification of cause helps for the further treatment pathway. Early identification of surgical causes and pediatric surgeon involvement. Age appropriate differential need to be considered. Most common cases are benign, and appendicitis is the most common surgical cause. Thank you everyone for the patient listening. Hello. Anyone can speak. Am I audible? Okay, I can see a few messages here now. Yeah, most of you have answered the cases like intussusception or sprung, econium plug, okay, DKA, very nice. Yeah. How to suspect Meckel's diverticulum, Dr. Srinivas? Meckel's diverticulum can present with pain abdomen along with hematochezia. So when there is severe acute onset bleeding, hematochezia with involvement of significant hemoglobin drop, it can be the most of the time that Meckel's diverticulum pain abdomen may not be present, may involve asymptomatic intussusception as well, with significant hematochezia with fall in hemoglobin. So you should consider early in these cases. If there is active bleeding, you can give it a Meckel scan. If there is no active bleeding can go with the RBC pool scan, or if no involvement, you can go with Meckel scan as well, no active bleeding.
Can you please unmute us so that we can comment? Dr. Devendra Sarin wants to do that. I think we can put in a question, sir, because some people ask questions, most of them discuss about other aspects. So please put on the question over here.
Dr. Anjali Reju, like posted regarding a case here, like condition, chronic abdominal pain on and off. In investigation, all investigations are within normal limits, but still complaining of pain. So this is important here. We should look at, this is the functional pain. It doesn't respond to the routine medications. The pain, we should first look at the characteristics of the pain. The pain is periumbilical with short duration, resolving spontaneously. Otherwise, active child, no red flags. If there are any red flags, he should be further evaluated with upper endoscopy and colonoscopy, with even if requires like capsule endoscopy. If there are no red flags, otherwise healthy child, mild intermittent pain resolves spontaneously, then we should look at the functional pain abdomen, like functional GI disorders, or nomenclature is changed to disorders of gut-brain interaction. So these functional pain abdomens, whenever there is children there, we need to look at the functional constipation first by looking at a simple plain X-ray abdomen and take the history of the constipation as well. If there is constipation, treat them. If disappears, if pain abdomen is secondary to constipation, disappear. If it is not, it is the functional pain. Counsel pain regarding what is functional pain. So it is not the disease inside the abdomen or disease inside the brain, but it is due to the interaction is getting disturbed. Either it is visceral hyperalgesia or it is visceral hypersensitivity in the brain. And peripheral or central hypersensitivity can cause pain. So these children, parents need to be reassured. Very important. If parents get apprehensive and anxious, child may also reflect the same thing. If parents are counseled, educated enough, and should send children to school regularly, and we should make children play at least 1 hour per day. Sometimes you can involve with like tryptamine and medications, while also looking at the other non-pharmacological therapies like psychological as well as yoga, meditation. We should involve in all four limbs of the therapies. Okay, pharmacological, non-pharmacological like physical exercise, psychotherapy, or and also some yoga meditation as well. Does all newborn with passage of large amount of meconium with prior distension of abdomen should we suspect Hirschsprung's disease before USG abdomen? Yeah, you can suspect delayed here, the delayed meconium passage. Not all children, but children with delayed meconium passage with marked distension of the abdomen. Then you should suspect not only Hirschsprung but meconium ileus, meconium plug. This is you can also suspect. Okay. Most of these children with contrast enema for the further diagnosis. How to identify constipation in erect abdomen? Okay. So constipation in erect abdomen. So you have to look at the you can divide the abdominal compartment in three quadrants in X-ray. I think you can explain this. So are you able to visible this drawing? So X-ray abdomen need to be like this is the spine. Draw a line from spine to the like pelvic organ from here at the level of iliac waist. From there you draw one more line to the right lower quadrant, one more to the left lower quadrant. Okay, this is you have to divide abdomen into three quadrants. Then you look at the large bowel shadows. Okay, large bowel shadows in the X-rays. So there is a scoring of Bloor and Bletkin for the constipation uh, grading. So normally some stool can be present in the right iliac fossa here, and some stool can be seen in the rectum here. Okay, otherwise there should be homogeneous bowel pattern from ascending colon, transverse, descending colon, and sigma. There should be homogeneous presence of gas. If there is absence of gas with intermittent fecal loading, you can see some drop-like patterns, or you can see some large fecolis. So if it involvement of there is one segment of the bowel, okay, discontinuous involvement of the one segment bowel, you can say mild constipation, or continuous involvement of the one segment or multiple segment, you can label it as a moderate constipation. Continuous involvement of multiple segments along with distension of the bowel, then you can label it as a severe constipation. So this is how it helps. And you can ask or sensitize the radiologist to look for the intestinal ultrasound as well. Most of the radiologists, they look for the signs of obstruction. If there are no signs of obstruction, they do not comment on intestines. But if you them repeatedly ask what you want and sensitize the radiologist enough, they can pick up fecal loading even in the ultrasound as well. So what antispasmodic to be given for pain? So you can give in children below 6 years. You can give cyclopam, and above 6 years you can give buscopan. These are the antispasmodic can be given. Any role of probiotics? They are involved diarrhea and dysentery. There is definitely role of probiotic. In functional abdominal pain, there is controversial role. You can prescribe in few cases. What is significant mesenteric adenitis? This is important again because many of our children are overly diagnosed with mesenteric adenitis. Mesenteric adenitis is diagnosed when there are 3 or more mesenteric lymph nodes with more than 8 mm in the short axis diameter. So here the important is short axis diameter should be more than 8 mm. There should be more than 3 in number. Then you call it mesenteric lymphadenitis. Okay. In there, acute mesenteric lymphadenitis can mimic like acute appendicitis, but treatment is simple: paracetamol and hydration. If similarly mesenteric lymphadenitis presents beyond 4 months, you label it as chronic mesenteric lymphadenitis. Then you have to evaluate for the other diseases like tuberculosis, lymphomas, and other brucellosis and other conditions. Okay. Acute mesenteric lymphadenitis is simply hydration and paracetamol. If there are other signs of infection, you can give antibiotics, but otherwise no need to treat any antibiotics. You need to treat the underlying conditions. So same one more question, the acute mesenteric lymphadenitis is significant. It should be at least 3 mesenteric lymph nodes more than 8 mm in short axis diameter. Short axis length, you can say length. Yes, yeah, functional abdomen pain is very important. Important causes of school absenteeism, anxiety in children and parents, and doctor shopping. These are the very important. So functional abdomen need to be picked up early. Look for the red flags and the characteristics of the pain abdomen, growth, and other parameters. Sickles. So mesenteric lymphadenitis, most of the time it is overdiagnosed. So look at this, when you take 5 mm as the cutoff, most 60 to 70% of the normal children also comes into the diagnosis of mesenteric lymphadenitis. So 8 mm is the better cutoff. And when you use the 8 mm cutoff, very few are diagnosed with mesenteric lymphadenitis. So one more question, should give polyethylene glycol with electrolytes or without electrolytes in cases of constipation? How to manage iron deficiency with constipation once we start hematemesis constipation infections? Okay, here. So first question is the polyethylene glycol with or without electrolytes. when we are going for disimpaction, that means when we are going for large volume polyethylene glycol or bowel wash, then we have to use polyethylene glycol with electrolytes like Pegleg and Movicol. We have this, these are the polyethylene glycol with electrolytes. So disimpaction is, we should must use with electrolytes. When it's come to the maintenance and induction of the constipation, we can use PEG without electrolytes as well. Okay. So one advantage of PEG without electrolytes is generally tasteless, odorless. Okay. You can mix within juice or milk or other liquids as well. When it's come to the polyethylene glycol with electrolytes, it has some taste, though it is acceptable or tolerable by many of the patients, almost 90%. But the without electrolytes has more bland than the with electrolytes. So with the during the disimpaction, with electrolytes is must. In constipation, you can use either with electrolytes or without. How to manage iron deficiency with constipation? Okay, whenever there is iron deficiency with constipation, we know it should be it is like a warnings or red flags, anemia in constipation. Okay, so we should evaluate whether it is nutritional anemia or it is involvement of GI involvement like bowel inflammation secondary to Hirschsprung's enterocolitis, malabsorption, worm infestation. We need to look into those things. If it is nutritional anemia or worm infection, then treat accordingly. So here that iron deficiency with constipation, we need to give them now nowadays available of liposomal iron is available. So like Tosiran is available where we give any very low doses of iron and most of them get absorbed. It can help. And if it is not available in the vicinity, you can give high fiber diet with green leafy vegetables, high fiber diet, which mitigate the constipation effects of the iron as well. Or you can give it low doses. Most of them nowadays, most of the studies says 3 mg per kg per day is sufficient, which is equivalent to 5 mg kg per day in the long-term output, long-term outcome. So start with low dose like 3 mg per kg. If available, start with the like liposomal iron. If not available, start with low dose like 3 mg per kg, and also advise them to consume lot of fiber rich food. Dr. Malini asks, for some children, periumbilical pain, abdomen, after some time after milk consumption for few days. It reduces after reducing and stopping milk for some time. Can it be abdominal pain due to some temporary lactose intolerance? It can be. You also look for the other associated symptoms like bloating, perianal rash, or diarrhea. Definitely, it is lactose intolerance. If not, it can be sometimes milk protein intolerance as well. Okay. Excessive milk consumption causing pain has multiple pathophysiology, like excessive calcium in the milk competes with the magnesium, which causes further decreased motility. And when we consume excessive milk, there will be replacement of fiber containing food as well. This will lead to again lower bulk forming stool. And the calcium, excessive calcium in the milk can also bind to the fatty acids, which lead to the soap-like formation and hardening of the stool. These are the multiple mechanisms which high consumption of bovine milk especially causes constipation, or it can also cause like casein is a very slowly digestible protein. So it leads to the gastroparesis as a slow motility. It can also lead to the milk protein allergy, it causing that acute symptoms. If symptoms are acute onset within 2 hours, it can be the IG mediated allergy most likely. If more than after 4 hours, it can be the non-IG mediated or mixed mechanism. So, yeah. As I told, if it acute mesenteric lymphadenitis, so many times USG abdomen shows mesenteric lymphadenitis. How to approach? First, we need to look at the is it really mesenteric lymphadenitis? As I told, it should be at least 3 lymph nodes, and the short axis should be more than 8 mm. Then only label as acute mesenteric lymphadenitis. If it is acute, treat with hydration paracetamol. If there are underlying other causes like dysentery or diarrhea, treat it. If not, follow up and look for the repeat ultrasound after a month and see. Choice of laxative in newborn, infants and children. Okay. When it's come to the children and infants, pegs are very safe and first line laxative from the infants to the geriatric population. So pegs are very safe laxatives. When it's come to the newborn, we don't have robust studies uh, to tell that it is very safe and efficacy. In newborns, we can use that Dufalac or lactulose as the first line. When you need disinfection newborn, use normal saline or glycerin enema. And maintenance laxative, you can use Dufalac or lactulose till 6 months. Thereafter, you can shift to the PEG. So, second stimulant laxative, you can use either paraffin and sodium picosulfate, available as smooth syrup. As a second drug. Most common cause of mesenteric lymphomatitis, mostly due to the bowel infection. Okay, and it is very non-specific symptoms. Any bowel infection can cause it, even parasitic, bacterial, viral, but most of them are self-limiting. Doesn't need any major treatment. Only thing you need is the hydration. At the time you have to give support. Dosage of proctoclysis enema. So this is mostly non-absorbed from the intestines. So we give about 2 years, we give full 100 enema in severe disimpaction cases. Above 1 year, you can give like 2 to 5 ml per kg according to the, and you should ensure at least 2 to 3 stools after enema. If not passing after 2 ml per kg, you can give one more enema as well. Drug of choice for disimpaction. Disimpaction drug of choice is PEG. If not palatable or child is not accepting, then enema for 5 days. Enema for 5 days or PEG in large volume like 20 to 40 ml kg per hour for 5 hours at least. Any age cut off to use PEG. Above 6 months we are safely using. FDA approval for children above 2 years, but there are many randomized control studies to say it is safe in above 6-month children. Yes, no, stimulant laxative should not be used early in the course, which may causes habituation. So always use like osmotic laxatives like PEG or Duflac. And every child who are suffering from chronic constipation and chronic pain abdomen, we need to disimpaction. We need to disimpact them. Then only this laxatives work better. If you're not able to disimpact them, then laxative doesn't work appropriately and no appropriate symptoms improvement as well. So disimpaction is very important, followed by maintenance doses of laxatives in constipation. So thank you everyone. I'll end the session now.